Shall we start, sir?
Yes, sir. Sure, sir.
Yeah, tech support team, you just please give the countdown and then I can request doctor to start.
Okay, we are starting in 3, 2, 1. Please start, sir.
Distinguished guests, it is an immense pleasure to welcome you all for this online educating platform. I request Dr. M.R.A. Rafique, sir, Senior Diabetologist from Madurai, to proceed with his presentation. Sir, you can start, sir.
Thank you. Thank you, sir. I hope my slides are visible and I am audible too.
Yes,
Yeah,
sir.
sir, visible and audible, sir.
Thank you. Respected senior members and my dear friends, first of all, I would like to thank the organizers for arranging this web meeting on a novel drug for the management of type 2 diabetes called imiglamine. So we all know type 2 diabetes is a progressive metabolic disease due to relative or absolute insulin deficiency. So in type 2 diabetic patients, the relative insulin deficiency as the duration of diabetes increases, and with the available management of type 2 diabetes, slowly the beta cell causes exhaustion of the pancreatic beta cell occurs. So at one point of time, most of the patients, they require insulin to control their blood sugar and to prevent the diabetic complications. So the selection of the drug is very important to control the blood sugar, at the same time to prevent the excessive pancreatic beta cell exhaustion. So the burden on the pancreatic beta cell has to be curtailed by selecting the drugs which acts on the pancreatic beta cell in a gentle manner and through the physiological manner. So for that, in the recent years, so many drugs are available for the management of type 2 diabetes, which use the insulin physiological manner, and at the same time, it avoids the usage of insulin. For that, DPP-4 enzyme inhibitors available, and SGLT2 inhibitors again is a novel mode of action. It increases the excretion of glucose through the kidney. So in that line, so the one another drug, the imiglamine, is again a very novel agent, which is very useful for type 2 diabetes management. It has a unique mode of action. Today we are going to discuss some beneficial effects of this drug and how we can place this drug in the our type 2 diabetes management. So imiglamine is a need of the hour. So the drug has a dual mode of action that is designed to increase the insulin secretion in response to glucose and to improve the insulin resistance. So here, sulfonylurea is one another drug which increases the insulin secretion, which acts directly on the pancreatic beta cell to secrete the insulin irrespective of the glucose control. When even the blood sugar is on the higher side or on the lower side, the sulfonylurea acts continuously on the pancreatic beta cells to secrete more of insulin. So that is why the risk of hypoglycemia and weight gain is more common with sulfonylureas. And at the same time, this drug, it improves the insulin resistance also. So insulin resistance means it is increases the insulin sensitivity. So for that, already we are having two drugs. That is metformin is the golden standard drug to reduce the insulin resistance. And the another drug is pioglitazone. Glitazones is again another group of drug which improves the insulin resistance. So in that order, the imiglamine is again the one another drug which is very useful to control our type 2 diabetes in our type 2 diabetic patients. So this is the first of the group of the oral tetrahydrotriazine compounds. It has a dual mode of action. It acts by increasing the insulin secretion in response to glucose, and at the same time, it has improvement in the insulin resistance. So the new drugs approved for the management of type 2 diabetes with a differentiated mechanism of action. So it is hailed from the Japan in 2021. So Japan is the first country in the world to approve imiglamin in the management of type 2 diabetes. Later, it was approved by our drug authority of India, the DCGI, and it is supported by numerous preclinical and clinical studies. And the phase 3 TIMES trial, that is a trial in imiglamin for efficacy and safety program, managed jointly by Poxel and Daya Nippon Pharma of Japan. So this is the only oral compound with the dual mechanism of action. It's directly designed to both increase the insulin secretion in response to glucose and to improve the insulin resistance. So this is the mechanism of action of imiglamine. So it acts through the salvage pathway, that is nicotinamide, and it acts on the pancreatic beta cells at the mitochondria. So it improves the ATP and ADP and other amplifying pathways. It increases the calcium in the endothelial cells, and thereby it causes insulin secretion. So this is the different mode of action and compared to the sulfonylureas. So at the same time, it has a unique mode of action on the mitochondria. So in the mitochondria, it partially inhibits the complex 1. It reduces the renin-angiotensin species formation, and restores the complex 3 function, and it prevents the MPTP opening and increases the ATP generation in the beta cell. So this prevention of MPTP opening causes lessening release of the pre-apoptotic protein. So we all know the apoptosis, the programmed cell death. This is responsible for the progressive decline in the beta cell function. So by modulating the mitochondrial function, so it reduces the apoptosis of the pancreatic beta cells. So thereby it improves the beta cell function and causes beta cell protection. So it increases the glucose dependent insulin secretion and prevents the beta cell death and increases the functional beta cell mass. And then at the level of the liver, it reduces the excessive gluconeogenesis and decreases the steatosis. And in the periphery, especially at the muscular level, it increases the insulin signaling and stimulates the glucose uptake. So thereby it reduces the insulin resistance. So coming to the pharmacokinetics and pharmacodynamics, the dosage available 1000 milligram twice daily. So we can start this drug is 500 milligram twice daily and may increase up to the maximum of 1000 milligram twice daily. So it has a very low protein binding, 1 to 8%. So the urinary excretion is unchanged. So clearance is driven by the creatinine clearance. So no drug-to-drug interaction with metformin, sitagliptin, or cimetidine. And at the heart levels, no QT or QTC prolongation. And no difference between the Caucasian and Japanese subjects. So coming to the special population. So as per the innovator, no clinical trial have been conducted in patients with moderate to severe renal dysfunction. So using the efficacy and safety indicator and administration is not recommended. So the Indian regulators have advised not using imiglamin in any dose in people with type 2 diabetes and chronic kidney disease with eGFR less than 45 ml per minute. That is CKD stage 3B and beyond. So in hepatic patients, it's safe and well tolerated in patients with moderate hepatic impairment. So the clinical trial have not been conducted in patients with severe liver dysfunction. So pregnancy, as usual, is not advisable. And lactation, if the patient is already continuing the drug, so we can advise them to take. But we need further studies to endorse this drug during lactation. So coming to the clinical trial experience, so This is a 18-week phase 2 efficacy trial. Here they observed the dual mechanism of this drug. So it increases the insulin secretion and when compared to placebo, and it has an improvement in the insulin action. So in both these parameters, it has a favorable effect with the imiglamin when compared to placebo. So imiglamin also increases the glucose-dependent insulin secretion and improves the beta cell function in patients with type 2 diabetes. So this the study. So the aim of the study is to assess the glucose-stimulated insulin secretion effect of the imiglamin. So double-blind study, around 33 patients have participated. So the treatment for 7 days and the insulin secretory response to glucose is raised by 112%. Both first phase secretion as well as second phase secretion is improved. But predominantly the first phase of insulin secretion is more pronounced when compared to second phase insulin secretion. And imiglamin improved the beta cell glucose sensitivity by 36% and tended to decrease the hepatic insulin extraction by 13%, and imiglamin did not affect the glucagon secretion. So this is another study for efficacy and safety of imiglamin in Japanese patients with type 2 diabetes, a 24-week trial. The aim of this study to assess the efficacy and safety of imiglamin monotherapy compared with placebo in Japanese patients with type 2 diabetes. The patients were randomly assigned to receive the oral imiglamin 500, 1,500 milligram and placebo twice daily. The primary endpoints was the placebo-adjusted changes at the end of 24 weeks in HbA1c. So the conclusion of this study, so given the marginal increase in the efficacy with 1,500 milligram versus 1,000 milligram dosage, along with the potential for the gastrointestinal tolerability issues, the dosage of 1,000 milligram twice daily was selected for subsequent usage in phase 3 clinical trials. And there's another study, TimeTalk trial, was observed to meet the primary endpoint with the statistically significant A1C placebo-corrected mean change in the baseline of 0.87%, as well as its main secondary endpoint, including the fasting plasma glucose. In TimeTalk trial, so the safety and efficacy was observed is again 52 weeks trial. Around 714 Japanese patients with type 2 diabetes have participated. So here 1,000 milligram of imiglamin was orally administered twice daily in continuation with the existing anti-hyperglycemic agents. And imiglamin observed to show an A1C decrease from baseline ranging from 0.56 to 0.92%. So which is very good effect when compared to other placebo drugs. And imiglamin was also observed to demonstrate the robust efficacy benefit in combination with type 2 diabetes with the DPP for enzyme inhibitors. So here DPP for enzyme inhibitor, again, it acts in a physiological manner through the GLP-1 mechanism. Again, it acts on the pancreatic beta cells in glucose-dependent manner. So when the glucose level is on the higher side, the drug acts on the pancreatic beta cells to extract more of insulin. Similarly, imiglamin is also in glucose-dependent mechanism. It acts on the pancreatic beta cells to secrete more of insulin. And in TimeTalk trial, again, the efficacy and safety was observed. Around 215 patients with added to insulin therapy with insufficient in glucose control. And at the end of 36 weeks, the TimeTalk and 218 patients are completed. The first 16 weeks of study were treated with imiglamin as well as insulin therapy. And the results revealed the A1C decrease from the baseline of 0.64% in patients receiving imiglamin for 52 weeks and 0.54 in patients receiving imiglamin and insulin for the last 36 weeks. And in chronic kidney disease patients, so this is the observation from TimeTalk 1, 2, and 3 trial on imiglamin. The A1C reduction with the CKD patients, the CKD stage, various stages. The stage 1, 2, 3 was observed. So here the times 1 trial 0.3 percentage of stage 1 CKD, and stage 2 0.8 percentage, and stage 3 0.6 percentage of A1C reduction was observed. And in time 2 trial, the stage 1 chronic kidney disease patients, the A1C reduction ranging from 0.2 to 0.95 percentage, and stage 2 patients again 0.0 to 2.95 percentage. In times 3 patients, the stage 1 and 2 patients, 0.72 and 0.64 A1C reduction was observed respectively. And this is one of the paper to reveal the effects of imiglamin on daily glycemic profile evaluated by intermittently scanned continuous glucose monitoring. The aim of the study to evaluate the short-term effects and safety of imiglamin in terms of glycemic control as assessed by intermittently scanned continuous glucose monitoring. So this is another retrospective observation study. 32 patients have participated, and the patients was monitored more than 4 weeks. And the results reveal the glycemic value differences before and after imiglamin administration is evaluated by intermittently observed continuous glucose monitoring. So the before imiglamin, the mean glucose level is 161, and after imiglamin is 141. And the time in range is an important observation. So before imiglamin is 70 percentage, and after imiglamin is increased to 82 percentage. And the time below range, again, it's very important to evaluate the hypoglycemic episodes. It is literally nil. And time above range is also reduced from 28 to 17 after imiglamin observation. And imiglamin clearly shifted a daily glucose profile into appropriate range in Japanese type 2 diabetic patients, indicating a short-term improvement in the glycemic control. So coming to the phase 3 clinical trial report. So this is the multi-centric randomized double-blind placebo-controlled comparative prospective phase 3 clinical trial to evaluate the efficacy, safety, tolerability of the imiglamin tablets in patients with type 2 diabetes inadequately controlled with diet and exercise alone. And the results revealed the mean changes in the HbA1c from baseline to end of the study is more prominent. The mean change in the glycosylated hemoglobin at the end of 16 week is 0.73 with 1000 milligram of imiglamin and compared to placebo group. And fasting plasma glucose reduction is also reduced up to 13 milligram percentage when compared to placebo, where it is raised to 7.9 milligram percentage. And the 2-hour postprandial plasma glucose reduction is also well observed in imiglamin group up to 21 milligram percentage, and when compared to placebo trial. So adverse events related to the other placebo groups is more or less similar. No unwanted side effects in the form of nervous system, gastrointestinal side effects, or infections, infestations, or genital disorders. So coming to the conclusion, so the imiglamin is the novel anti-diabetic drug that represents a new class of oral medication targeting type 2 diabetic patients. So it combines a unique mechanism of action to improve the glucose control by addressing both insulin resistance and beta cell dysfunction. So it belongs to glymin derivative. The main mechanism of action, it enhances the mitochondrial function, which is pivotal in glucose metabolism. And at the same time, it reduces the oxidative stress and improves the insulin production and improves the insulin sensitivity. And it protects and improves the pancreatic beta cell function, leading to increased insulin secretion in response to glucose. and decreases the hepatic gluconeogenesis. Thereby, it controls the fasting plasma glucose. So the important mechanism of this drug is the mitochondrial targeting. So that is why this drug is otherwise called as is a mitochondrial modulator. So mitochondria plays a central role in the cellular energy metabolism. So the dysfunction of mitochondria is implicated in the pathogenesis of type 2 diabetes. So imiglamin restores the mitochondrial function and improves the cellular energy balance and reducing the glucose production. And as already discussed, it has a dual mode of action. So it improves the insulin secretion and at the same time improves the insulin resistance. And it improves the oxidative stress also. And it has a favorable effect in modulating the liver function. So it has a favorable effect in hepatic steatosis also. So clinically, it is very useful to control type 2 diabetes by improving fasting as well as postprandial control. So thereby, it also has a favorable effect in reducing the HbA1c, and it can be combined with other anti-diabetic medications, metformin or DPP-4 enzyme inhibitors, or SGLT2 inhibitors, sulfonylureas, or pioglitazone, or even with insulin. And it has a unique mode of action. It acts on the pancreatic beta cells in glucose-dependent mechanism. So the risk of hypoglycemia is negligible, and it improves the insulin sensitivity also. So it is well tolerated, and again, it is weight neutral. So these are all some of the favorable effects of imiglamin. So this originally, this is the drug. Its action is similar to that of metformin. So here some of the comparison between imiglamin and metformin. So the differences in mechanism of action. So in vivo, the imiglamin has glucose-stimulated insulin secretion, and it has a favorable effect in reducing the insulin resistance. Whereas in metformin, no reported effect on the insulin secretion, and it has a favorable effect in improving the insulin sensitivity. So this is one of the golden standard drug to improve the insulin resistance. And cell and organ, it's glucose stimulated insulin secretion. So metformin has no action on the pancreatic beta cells. And intracellularly, imiglamin is a competitive or partial mitochondrial complex 1 inhibition. So no decrease in the mitochondrial respiration. So it increased NAD plus synthesis is potentially via NAMPT and increased glucose responsive intracellular calcium. Thereby, it increases the insulin secretion. Whereas in metformin is the uncompetitive mitochondrial complex 1 inhibition. It has decreased insulin respiration, no increase in the calcium plus, so no effect on insulin secretion. So coming to the CV safety, so for in each every drug, the CV safety is very important. So recent data suggests that imiglamin prevents the death of a human endothelial cells by inhibiting the mitochondrial permeability. So without inhibiting the mitochondrial respiration, and which may improve the cardiovascular risk profile in patients with type 2 diabetes. So the QTC prolongation is very common with most of the drugs. So the absence of QTC prolongation through the QT study with imiglamin, first class of oral anti-diabetic drug in type 2 diabetes mellitus. So here the QT study was conducted to establish the electrophysiological effects of therapeutic and supratherapeutic dosage of imiglamin and cardiac repolarization. So the conclusion was this through the thorough QTC study demonstrated that therapeutic and supratherapeutic exposure of imiglamin did not induce the QT or QTC prolongation with strong confidence on evidence by the assay sensitivity. So here the comparison of various anti-diabetic medications with imiglamin. So metformin, sulfonylurea, DPP-4 enzyme inhibitors, SGLT2 inhibitors, imiglamin, and thiazolidinediones. So here metformin improves the insulin sensitivity. It has no action on the beta cell function or action on the mitochondria. Sulfonylurea, it causes excessive stimulation of beta cells, and DPP4 enzyme inhibitor as physiologically improves the insulin secretion through GLP-1 mechanism, but no action on the insulin sensitivity or mitochondrial action. SGLT2 inhibitor is a different mode of action. It increases the excessive excretion of glucose through the kidney, but it has some favorable effect in improving the insulin sensitivity by reducing the body weight. Whereas the imiglamin has favorable effect in reducing the insulin resistance by improving the insulin sensitivity, and it glucose dependent beta cell stimulation causes minimal secretion of insulin, and it has a favorable effect in mitochondria as a mitochondrial modulator. And thiazolidinedione has favorable effect in insulin sensitivity, but no action on the beta cells or action on the mitochondria. So likewise, imiglamin scores better over the other drugs by improving the insulin sensitivity and improvement of the beta cell stimulation and mitochondrial modulation. So coming to the conclusion of today's session, so the currently available oral anti-diabetic medications addresses only one facet of type 2 diabetes. So imiglamin is the only oral compound with dual mechanism of action. Imiglamin simultaneously targets all the three organs of diabetes, that is pancreas. It acts on the pancreatic beta cells in glucose-dependent mechanism to secrete more of insulin. And at the level of liver, it causes reduced hepatic glucose production. And at the level of muscles, it increases the uptake of glucose by improving the insulin sensitivity. And imiglamin has been shown to have a positive impact on skeletal muscle glucose uptake, hepatic glucose production, and beta cell apoptosis by modulating the mitochondria. And imiglamin demonstrates good efficacy with monotherapy and also in combination with the maximum benefits seen with when used concomitantly with DPP4 enzyme inhibitors. So with this, I conclude my talk. Thank you for patient hearing. If you have any queries, I am eagerly waiting to answer your questions. Thank you.
Thank you. Thank you so much, sir, for your wonderful explanation. And delegates, you can unmute yourself and you can ask your query to Dr. Rafique, or you can post it in a chat box.
I think there is one question in the chat box. How will you choose a patient to initiate imiglamin? Yes, sir. So this is a very useful drug which acts essentially similar to that of metformin. So in the place of metformin, we can use this imiglamin for our patients. It can be combined with metformin also. So as in suppose the patient newly detected having mild to moderate hyperglycemia, we can use this imiglamin. It's a favorable effect on the pancreatic beta cells as well as to improve the insulin sensitivity. So because of this favorable effect, no risk of hypoglycemia, and at the same time, no risk of increased weight gain. So the actions are more or less similar to that of metformin. So in the place of metformin, if the patient is intolerant to metformin or is having increased GI side effects, so instead of increasing the dosage of metformin, we can use imiglamin. The next question from Dr. Sundar. So because of its mitochondrial action, does it have any other pleiotropic effects on lipids? So the studies they have shown is mainly for the control of blood sugar, sir. So we have to wait for the further studies for the pleiotropic benefits of lipids, but according to its mechanism of action, so definitely it has some positive pleiotropic benefits in the vascular system as well as on the lipid parameters. So the one thing I want to emphasize, the mitochondrial dysfunction is the important culprit for the progression of type 2 diabetes mellitus. So by adding this imiglamin to each and every type 2 diabetic patients, definitely we can modulate the mitochondrial function. So thereby we can not arrest, we can slow down the progression of the type 2 diabetes. So this is a very long-standing observation. So for that, we have to wait for a longer period. So as we continue this drug in our type 2 diabetic patient for years, so definitely we can observe some positive feedback with respect to the decrease in the progression of type 2 diabetes. So as already discussed, it by modulating the mitochondria, so it definitely reduces the apoptosis of the pancreatic beta cells. So thereby it prevents the progression of the disease. So it improves the beta cell function, and preservation of the beta cell function is also there. So thereby it has a favorable effect on the glycemic control and at the same time for the vascular benefits. Thank you. So next question from Dr. Arun Prakash. Can we use this drug as a monotherapy in newly detected type 2 diabetes? Definitely yes, sir. So suppose the patient is not able to tolerate metformin, or if you want to control the blood sugar safely, so in newly detected type 2 diabetic patients, we can safely prescribe this drug to the maximum of 1000 milligram without any side effects. So the GI system is well tolerated to the maximum of 1000 milligram. So it controls both fasting as well as postprandial effectively. So we can safely prescribe this drug to newly detected type 2 diabetic drug as a monotherapy. So follow up the patient. If it is not adequately controlled, then we can add some other drug along with imiglamin. Thank you, sir. The next question from Dr. Uday Kumar. Sir, how much percentage of reduction you have seen on imiglamin and HbA1c so far with your patients? Good, sir. So the efficacy wise, when compared to metformin or other anti-diabetic medications, it is less efficacious. So in my experience, up to 0.4 to 0.5 percentage of HbA1c reduction was observed. But apart from this efficacy benefits, so it has a favorable effect on the mitochondria. So by modulating the mitochondrial function, it has a definite action in the prevention of the progression of the type 2 diabetes. So for that, we can use this drug in all of our type 2 diabetic patients. Even I have tried this drug in type 1 diabetic patients also. They also some amount of blood sugar reduction and HbA1c reduction up to 0.4 to 0.5 percentage was observed, sir. Thank you, sir.
Sir, thank you, sir. I think there are no more other queries. With your permission, may I give a vote of thanks, sir?
Yes, thank you.
Should I close?
Sure, sir.
So, dear sir, it was indeed a pleasure and honor having you in this event. We, on behalf of Zydus Life Science, would like to extend our sincere thanks for your comprehensive session. We are sure our delegates would have got enlightened regarding the usage of imiglamin, as you have covered all the possible aspects in your session. At the same time, we would like to thank all the delegates for their presence and patient hearing. Thank you all once again. Have a great evening. Thank you so much, sir.
Thank you, sir. Thank you, and good night.
Tech support, now you can close the meeting.